So I've had some great conversations already with several of y'all, and I feel like a fish out of water a little bit, but I hope I can give you some perspective of some of the things that we do at UCSF, and also a concept that I think might be useful and interesting to talk a little bit more about. And that is something that we either call the vector of health or the trajectory of health. So I just have a few disclosures of companies I either consult with or work for. This was a statement put out by the WHO, basically, and it said, today, for the first time in history, most people can expect to live into their 60s and beyond. And this is something that many of us take for granted because most of us expect to live beyond 60. But if you're in a developing country, most of the advances that have happened in life expectancy have happened because young babies have lower mortality. But if you live in an advanced country like ours, it's primarily because the older people in our population have a lower mortality. So one of the things, though, is that we'd like to think that if we're living longer, that we're going to be living better than our parents. But that's not always necessarily true. And because aging is complex, if we describe it from a biological level, it really is the accumulation of damage. You know, we're born all fresh and a little baby, and we mature to a point to where we have full maturity, and then after that, we just start accumulating damage at a cellular level that eventually accumulates to the point to where it gradually decreases our physiological reserves and increases our risk of diseases, and it declines. We have a decline in our overall health capacity, and ultimately aging is fatal. So physical capacity is what I want to spend most of the rest of my talk on, and capacity really is synonymous with fitness. You can think of this as your individual capacity to undertake everyday tasks. But it's different than actual physical activity, because physical activity is actually, you're taking an action, you know, so you can have a capacity for physical activity but not actually be doing it. So what we are, the term that was coined recently by the WHO is the capacity to do these things more so than actually doing them. And if we look at this as it's kind of an intrinsic, something we're born with level, or something that's kind of inherent to who we are, we usually have a very high, stable capacity early in life. And then once we hit mid-adulthood, it starts declining a little bit. And then when we're older, we start going into a significant loss pattern. If we look at this, this is data from the WHO again. If we look at it as far as tertiles, which each one of these lines represents about 20% of the group in three different groups. Either this young group, you see the first group there at the 20 to 40 is the younger group, then there's a middle age and an older group, and the total number of people in this data set is about 13,000 people. But you can see that the capacity at between 20 and 40 is really nicely grouped and is very high. The range of this metric called capacity ranges from about 0 to 100. But then in middle age, you start seeing a broadening of the range. So there's some people that are really going quite low in their capacity, and some people maintaining high capacity. But then when we get into the older ages, in the 70 to 90 years old, the range, it really explodes. Some people go beyond a threshold that is coined the disability threshold. And that really is a threshold at which something's happened to where you need assistance to do daily things when you used to not need assistance at all. So why do we have this big broadening of the range of capacity? Well, let's first look at physical activity. You know, I would say most people that are targeting wearables are targeting this age group from 20 to 40 years old. You know, they're the ones that really like the wear Fitbits and so forth. And you can see that, but on this chart, if we look at the high, moderate to low physical activity in that age group, it doesn't make much difference in capacity. You know, if you're 20 and you've never run a marathon and you go, you know, I think I want to start running marathons, you can train and you can start running marathons and be pretty successful at it. You can't do that if you're 80. You can't say, you know, I've never run a marathon, I'm just going to start running marathons. You can't probably make to the level at which you could have if you have been running marathons for a long time. Your body's just not capable of doing that anymore. So at a younger age, physical activity doesn't seem to impact your capacity. It does in the midlife. You can see it broadens out a little bit. But now if you look in this last group, you can see it's broadened it out quite a bit. And look at the high physical activity group. They don't cross the disability threshold until about 85 years old. And the low physical activity group crosses that threshold, it looks like around 70, right? So we've got a 15-year range of a difference of reaching a disability threshold based on physical activity. And that's pretty profound. So physical activity adds about 10 to 15 years in your functional life. Now, there's another way of looking at this, which is a little bit harder to control, and that is your ability to manage on your current income level. Again, when you're young, doesn't matter. You can have a low income or high income, doesn't matter in terms of your overall health capacity. But when you get older, if you have a what's called impossible or always difficult to manage on your income, your capacity falls quite a bit. And that could be for many, many different reasons. But the take home there is that if you're older, it's better to have plenty of income so that you can manage your health better. Now, what happens when you fall off the wagon? If you're thinking of this from a capacity, which I think what I'm trying to promote here is that I think capacity is a good way to look at our health, and it's a metric that I think can be calculated by wearables or integrated across different devices. If you look at the trajectory of an individual, the optimum trajectory would be what's labeled here as A. You go through your whole life at this peak capacity of health. Everything's great until you get to like whatever age that you're going to die, then boop, it just falls off. So you go up to the moment of your death with full cognition, full function, full ability to live your life as you like, and then you just die. And that's shown here on curve A as it just goes down to zero. But then you've got other life events. You can see there's an unlucky individual that's curve C, where he started off at a high level early in life, but just had a gradual decline. That's not such a great profile because throughout your entire life, you just have this decline in your capacity. But then you have these other curve possibilities, which are B, which really you had a life event that occurred that caused your capacity to drop. And you either had no recovery of that, which caused your capacity to fall precipitously after the event, or you're able to recover back to the high capacity or somewhere in between. The problem with this type of description of health is that it's univariate. It's taken all the information that I showed you on income level, physical activity, and so forth, and trying to make one metric out of it. And so if we were looking at a curve like this and trying to figure out what was the interruption in B's life, was it cancer? Was it arthritis? Was it obesity? It's really difficult to know if you reduce all your data down to a univariate outcome. But the other aspect, though, is that what do you do if you want to change your life course? And here's an example of if you're early in life, you want to make sure that you reach your highest possible functional capacity. So this would be like when you're in your teenage years or even younger, you want to do sports activities, you want to really extend yourself to get the highest peak value so you can carry that through your life, or at least when you go into decline, you're starting at a higher value. And then midlife as an adult, you're trying to you want interventions that are aimed at slowing down the decline. So this might be jogging on a regular basis or working out or doing some type of sports activity, or possibly it's having a challenging job that keeps your cognitive abilities high. All those things help you maintain your capacity from declining as precipitously. But then the last category, when you're much older, when you would have this increased decline at older ages, the interventions are different depending if you're above or below this disability threshold. If you're above it, then you want to reassess what you were doing a little bit earlier in your adult life and try to stimulate those activities to keep the capacity high. But if you fall below the disability threshold, your options start to get really limited. Then you're in a situation where you're just trying to maintain quality of life. So how does big data help us in this situation? If we only have like what I just showed you, which is a single variable where your whole life's exposures and have been brought down to one variable, it's difficult to really understand how you do intervene and when you start going south in your health. So one approach would be don't reduce the variable down to a single univariate capacity variable. Expand the variable space and use a big data approach so that you have 1,000, maybe 1 million variables that now describe your life course, from the characteristics of your birth to the characteristics of your family to your exposures to your walking pace to the way that you talk on the phone. All these, which could be a cognitive predictor of your mood or of your drop in any type of intellectual capacity. So we can describe all these variables, though, still as a trajectory, where we think of now it's just many variables and it's going through space. And we're looking for when do we part off this trajectory? When do we start to part off the trajectory of health through all these variables into a new trajectory, which could be cancer, or it could be osteoporosis or heart disease. And so now, instead of having a single plot that's just one variable over time, we have something that looks more like a tree branch. That a tree branch would be three-dimensional, but just think of this as thousands of dimensions, where there's an optimum path to go through that space. And you want to see when you have a branching point into a new path and a less desirable outcome. And it would look something like this. And this would be a very desirable thing to have, and there are barriers of why it hasn't been done so far. One is privacy. How can you have all this information out there and know that it's not going to be used against you and it's only going to be used for you? The need for full course, life course population data is also something that we figured out a little bit, like on some variables, but not all variables of your life. And the need for having variables that are actually meaningful. This is a paper that came out 2 years ago, and it's about energy balance. And it's byline when something is not better than nothing. And what they mean by that is that sometimes we measure things or we quantify things, and it turns out to be so inaccurate that poor decisions are made on it. And the example they gave here is that energy intake and physical activity or energy expenditure are extremely difficult to know accurately, even if you're wearing all sorts of monitoring devices. And in this paper, they said that just doing a food frequency questionnaire will give you energy intake, how many calories you eat on a daily basis, but only with a bounding error of from 30% to 100%. So that's crazy amount of error, 100% error. The other is that wearable technologies are getting there, but there's still issues with their accuracy as well. And this is just a paper from JAMA last year that said that those that wore wearables on an intervention versus those that didn't, the ones that wore the wearables didn't lose as much weight in this dietary intervention as those that didn't have any wearables. So, it was the opposite effect of what you would think. And then I'll just close with showing you some of the technology we're developing, which is looking at the overall body shape as a health predictor, where we collect that optically, we register it with fiducial points, and then we predict bone density, body composition, and also direct health outcomes from that. And there's just an example of how we can predict the bone density of your femur using this type of modeling. And once we create the model, we can invert the mathematical equation back to an image that gives us this body shape. And so this is my last slide, and it's just a simple movie that shows what this model is. There's one of our models that we used in our study. me. I can't really show anybody else. And that's what your optical body shape looks like on this device. This will be basically showing you how we register people to each other and across data sets. What I wanted to show you is one specific example which allowed us to predict the bone density of your proximal femur, which is what we use to predict osteoporosis, just from your body shape. And it does so pretty well. What the model basically showed us is if you're tall and big, you have high bone density, and if you're really small, look like this, you have low bone density. It's pretty obvious, but it's interesting to see it mathematically transform back to the solution that you think of. So I'm gonna go ahead and just close with some acknowledgments here, my students and our funding sources, and thanks for the opportunity to talk to you tonight.